This is Dr. Jamie Kaufman, and this is Dr. Kaufman's Reflux Hour. Today I'm going to talk about acid reflux and the ears, nose, throat, sinuses, too. I'm going to talk about the larynx and voice problems next month because it's a bigger topic in itself to include here. I think there's a backstory that you need to know. I was going to be an ENT doctor, but I discovered that at my university there was a doctor doing laser surgery with a microscope just through an open mouth. And in any case, I became a laser surgeon. I essentially had the first non-experimental laser in the United States in 1978. And so I began having patients come from all over. And some of them had complications, and most of them looked inflammatory. So I began as basically talking about the larynx and pharynx, and I wasn't so aware of things like shortness of breath and sinus problems and so on. That said, I was called urgently to the bedside of a woman who was gasping for air like a fish out of water. I carried with me a small portable endoscope, an ultra-thin, that I placed through the nose. And when I looked down at her larynx, she had these two great, huge, almost like red broccolis, and they were obstructing her airway, and they're called granulomas. And they're caused by inflammation, and guess what? The inflammation is reflux. And they should be removed once if they're obstructing, but generally speaking, anti-reflux treatment will take care of small ones and prevent them from recurring if you have big ones. So next thing, I start doing pH testing, reflux testing, and I'm doing something no one's ever done before. The pH testing company, for me, did custom catheters where I had a pH testing chip right here, the best chips, the best pH chip you could buy, money could buy, and another one in the esophagus. And I began to look at pH monitoring. So understand that the data that I have over the course of my lifetime is derived from experience not only with probably 100,000 patients, but also with probably a third or half of them having pH monitoring. So I could correlate what I was seeing with what was being measured when we looked. That test is no longer available. So it has to do with Medicare and it has to do with GI doctors. GI doctors want to do Bravo or impedance. Neither of those are useful for respiratory reflux. They still call it atypical reflux, but respiratory reflux is ubiquitous. For every person who has heartburn, guess what? I'll give you the number. In a recent study, we found 14% of patients coming to me had heartburn. Now, you could argue that that's a special group because they know they have respiratory reflux, but in any event, more people have respiratory reflux than have, if you will, esophageal reflux. And respiratory reflux, by the way, is a new term for LPR. So, reflux testing is no longer available for people with respiratory reflux, and we'll talk about some of the options with some of the questions. I'm going to talk about the pharynx to start out with, and the pharynx runs from the skull base down to here, where you swallow, where your voice box is, and it's divided into three parts. The nose, nasopharynx, is basically, if you go back in your nose all the way, that's where your eustachian tubes are, sinus openings are nearby, and that goes right up against the skull base. And it goes all the way down to the palate. Essentially, when you look in the mouth, that's called the oropharynx. And that's basically palate and the back wall and tonsils, if there are tonsils. And then there's the hypopharynx, hypo meaning below. And the hypopharynx is also called the laryngopharynx because the larynx is the most important structure there. That aside, I'd like to talk about these conditions. Remembering that I've been doing 24-hour pH monitoring with the best equipment money could buy, and that equipment is no longer available. The GIs decided that they would do the reflux testing I mean, there may be some ENTs who are doing reflux testing, but the little thing they put in their nose, the Respec, I don't think is very valuable. So we'll get to that question again, but the nasopharynx, most important structure there are the eustachian tubes. And the eustachian tubes look like a little volcano with the crevice in the middle. And behind them there's a space. It has a fancy name, the fossa of Rosenmuller. So if you have reflux in the nasopharynx, there'll be a granularity, cobblestoning of the lining, a thick white mucus or pale mucus, and then obliteration of the fossa Rosenmuller and sometimes erythema or redness. I sort of came to hearing problems last. About 10 years ago, maybe it was more, a young man, I remember the case very well, I can still see his face. He was a 29-year-old computer person. He did some kind of tech with computers. And he came to see me, and he was very, very agitated. He said, I have ear problems. He said, I have fullness, I have pressure, I have pain, and I have tinnitus, and it's caused by reflux, and I've already seen, I don't remember the number, but it was some horrific number, like 13 or 19 doctors, most of whom told him it was in his head, was nonsense, but nobody believed the possibility that the ears could be affected. So I looked at him, and sure enough, he had all the findings I just described in his nasopharynx, rip-roaring, and red means he had reflux last night or the night before. He had all. So I did his 24-hour pH monitoring, and he refluxed almost all night. So put him on a very intense program, as intense as I could at that time. I didn't know as much as I know now. And the man came back to see me a month later smiling. So we don't usually ask patients, ENT doctors, if they have any ear symptoms, if they come in with a throat symptom, postnasal drip, or trouble swallowing. But we should ask about, do you have any ear symptoms as well? And it's important to note, however, that the tinnitus is extremely common, and most of the time it is not related to reflux. Tinnitus is caused by the hair cells in the organ of hearing that get damaged over time by loud noise and just by the process of aging. And as those dying or dead hair cells are physiologically not right, they tend to give off the ringing noise. The exact mechanism, I don't think, is known. So by far, if you have tinnitus, you should see an ENT, and that should be evaluated, usually with a hearing test, and you saw high frequency hearing loss. Just the same, if you have the constellation of pressure, pain, tinnitus, the idea that the eustachian tubes are blocked and not working substantially, then reflux certainly is the most common cause. Of the patients that I see and saw from that time forward, they were the smallest percentage. I can't give you a percentage. The majority came with voice problems because I was trained as a laryngologist with the laryngeal laser and so on. But still, it's a real thing, and it's important to know about. The next thing, is people have nasal stuffiness. And nasal stuffiness can occur because of reflux. In fact, if you look at the nasopharynx, you come along the pharynx, and then there's a little place that we could put a pond for collecting, let's say, acid and pepsin. So really, the nasopharynx is a place where it may sit there, one reflux event, and puddle there all night long. So sinus problems, if you have one sinus infection, terrible pain here, teeth hurt, associated with an upper respiratory infection, that's a sinus infection. If you have facial pain and pressure, and all your sinuses show, and this is very important, mucoperiosteal thickening, which is a fancy word for the lining of the bone of the sinuses is thick. That is not sinusitis. Unfortunately, some radiologists say mucoperiosteal thickening consistent with chronic sinusitis. This now gives physicians who may or may not be scrupulous to do balloon sinuplasty or surgery on these people who don't need it. So in my opinion, a lot of unnecessary surgery is being done for mucoperiosteal thickening. So get a hold of your CT scan before you decide to have any surgery or any procedure done. Nasal, it's interesting, the nasal thing, I've recommended spray for the throat, but the same company, if you go to an article on alkaline water, my last one, the man looks like he's made out of water. You'll see at the end of that the little spray bottles I recommend for the throat. The same company makes nose droppers. So for people who have problems, I recommend that before they get up in the morning, they squirt in the nose alkaline water, pH 9 or higher, Pepsin dyes at 8, and do it a second time. And this will help a lot. There's a question someone asked me later. Is a nebulizer of alkaline water a good idea? Just the same thing you use, for humidity during the winter. And the answer is it couldn't possibly be a better treatment for Pepsin dyes at pH 8. Where do you have it? I don't know, all over. So when you breathe in, you're getting through the nose, through the mouth, and so the nebulizer idea is a pretty good idea. But the nose drops work. One aside thing to note about that, people say sometimes that the water burns. And my experience is that it has something to do with people with severe reflux. Maybe there's a ton of Pepsin. I have no idea the mechanism. But as the reflux gets better, it goes away. So the nose and nasal congestion are certainly in the respiratory reflux ballpark. The oropharynx, people who have recurrent ulceration, like canker sores, often have reflux. It weakens the lining, and out comes the virus, which is living somewhere nearby. And so recurrent ulceration, there are other diagnoses, but reflux is a common one, as it can cause tonsillitis, enlarged tonsils, a big uvula. The uvula is too big. Sometimes it's hanging down on the patient's tongue, and it feels bad when they swallow, and the rest of the time it feels like something is there that shouldn't be there. And then comes the big one. Snoring and sleep apnea. When I was young, there was no such thing. It wasn't that we missed it. We've now had 2 generations of people who eat terrible diets, the worst in the world, 30% fast food, and it takes 20 years to get snoring and sleep apnea. You have to reflux night after night after night. And in my experience, you can examine the throat, and the throat, which should have the barrel, let's say, of a golf ball, has the barrel, if you will, of a marble. So that there's significant thickening of the lining, and the lining also looks like a whale blubber that's smacked together. We see the ups and downs. But one of the questions that's been asked that I've not been able to address because I'm no longer in practice in doing pH testing is, does a CPAP make your reflux worse? I don't know. I will say, if you have snoring or sleep apnea, at the end of this, get a pencil or a pen so you can take some notes. I'm going to give you 10 blog posts that if you read and you follow them, all of them, let's say, for a month, you can improve your reflux, maybe even cure your reflux. For you with snoring and sleep apnea, get a bed that goes up, never eat late, always take a Gaviscon before bed or one of the other alginates, and there's an article on snoring and sleep apnea. So I guess that's pretty much that for the oropharynx, except for one, burning throat. Now, throat burn is not a common symptom. If the throat burn occurs after the meal, and then you can attribute it to reflux. But if you're burning all the time, painful burning all the time, that's not reflux, although reflux can make it even worse. That has to do with the vagus nerve. And so I have an article, and you just type in neurogenic and up it'll pop. I only treat 3 things, and severe neurogenic symptoms are basically real pain with speaking neurogenic cough and burning throat. But those same people will also have burning tongue. And so that suggests this is a viral neuropathy. So word to the wise, it's not very common. So don't everyone out there say, I have a neuropathy and I need to be on Neurontin and all that, but you don't. So what else do I have to say? A hypopharynx, obviously laryngitis and its sequelae are number one. The big uvula can actually be hanging into the larynx, really causing problems for the patient. And granulomas I've talked about. Oh, I didn't finish the granuloma story. I was called to the bedside urgently to see a patient who couldn't breathe. And she had big granulomas. I literally wheeled her bed to the OR as they were setting up. We put her to sleep. I went in. We just didn't use tubes. We used to blow the air in and out. And I zapped out her granulomas, which took, I don't know, a minute. And then her airway was fine. And then she was treated for anti-reflux treatment. So that was my baptism by fire of really a reflux complication that was a potentially life-threatening one. So I don't want to talk too much about the hypopharynx except to say that globus and dysphagia, difficulty swallowing and a sensation of lump in the throat, are basically upper esophageal sphincter misbehavior, and I have an article on globus and an article on difficulty swallowing. So now I'd like to answer questions. I'm sorry I rushed through that, but I want you to know that pretty much any symptom in the respiratory system can be caused by, worsened by, or accelerated by respiratory reflux. So it doesn't matter what you have. If you have something real that's not reflux and you have reflux on top of it, it's going to get a whole lot worse. So the questions are very good. The first question, Pam, ironically, how do you recognize your ear, nose, and throat manifestations are due to reflux and not due to other causes? As far as symptoms are concerned, guess what? The lining of the respiratory tract are mucous membranes. So if you have reflux, you make more mucus. So the most common symptom of respiratory reflux is mucus. It's thick. It's hard to move, and it gets on your vocal cords. In fact, it'll change your voice if you're speaking. I remember hearing the president do that, and there was a clump of mucus on the vocal cords, and it took a while to get it off. So postnasal drip in its forms, that's not thin, thick, chronic throat clearing, a sensation of a lump in the throat, hoarseness, particularly alteration of the pitch or the singing voice, globus dysphagia, and shortness of breath, which I'm not going to talk about today, are really the most common symptoms. And for most people, having one symptom alone is unusual. So read about find the reflux finding score. I remember which article it's in, but it'll help you. And it's in both of my reflux books for adults. Use the blog. Use the blog. Use the blog. Many of the questions asked today are answered in the blog. And you can just type in hiatal hernia. That's one of the questions. I have a hiatal hernia and it does this and it does that. What do I do? And the answer is, if it's a 2-centimeter hiatal hernia, pretty much everyone has one. Just assume it's almost normal. Yeah, it means your lower valve isn't quite as tight as it would be if the diaphragm were right at the place where the valve is, but it's of no clinical significance. Small hiatal hernia should never be touched for any reason. If mucosal lining is okay, if we're not worried about something else. What if you've done Tess Ann? What if you've done everything, diet and lifestyle, and just have a weak LES? It's not that simple. You've got to go do a detox program that includes I'm going to give you 10 articles for a detox program. All of them. I mean, gum chewing, important, after every time you eat, or sucking on hard candy. So I'm going to give you 10. The answer is you still have reflux, and it has nothing to do with your LES. Now, if you have got rid of your reflux, and you don't like lying down at night, and you really have no other symptom, but you think you can get a barium swallow esophagram, and you should ask your regular doctor to order it, and it should be done standing up, upright, and supine lying down. If after a long period of treatment, self-treatment, you still think you have reflux, that is probably the best study for you, because if here's the valve and the reflux is going back and forth when you're supine or lying down, then there are other questions. And by the way, I'm doing consultations 2 days a week, and for you who are really, really stuck, do it. It's not cheap, I'm sorry. So Pam, I think you still have reflux. It's not just diet and lifestyle. I mean, what time do you eat? What time do you go to bed? Are you eating at 5 if you go to bed at midnight? How about doing that for a few weeks? Terrible taste. This comes from Jane, who's asked 3 times. This is the 3rd time she's asked this question. If I had to answer it, Jane, I'm sorry. You're very patient. Terrible taste every morning when I wake up, even when I take Gaviscon or Reflux Gourmet before bed and sleep on an incline. What else can help? The answer is you're not on a reflux program. The idea that there's a little pill or procedure that's going to make everything okay is just not right. The only way you can stop reflux, people take something, they have heartburn, they take a PPI and heartburn gets better. But those people have an increased risk of esophageal cancer over the years, because even though the heartburn is gone, esophagus is a quiet organ, the disease goes on unabated. And so there is a proof, very, very beautiful study, the Danish study, that shows long-term use of PPI is associated with an increased risk of esophageal cancer. Meanwhile, the question is, terrible taste in the morning is reflux, championship reflux. You get into a championship division, and when I get to the end, let's see. Get your pencils and papers. 10. Can reflux cause tinnitus? John, yes. I saw a surgeon that told me barium swallow doesn't show if you have acid reflux because the barium comes up. Obviously, if barium is coming up, you have reflux. That's one of the reasons it's done. It is not, however, a diagnostic test. If you have a normal barium swallow, you can still have reflux. It's done in the middle of the day. A host of reasons why it's one point in time. And it's really being done to look for other things, just motility, congenital abnormalities, the lower sphincter area, large hiatal hernias. We're talking about 6 centimeters and up. And certain things. You'll see, for example, if you have reflux, they'll say a cricopharyngeal bar, which is the upper esophageal sphincter misbehaving, and please don't let anyone operate on that, because the cricopharyngeus, or the upper esophageal sphincter, is the last barrier you have to reflux, to respiratory reflux. And the fact that it's not performing well, and it shows a cricopharyngeal bar, by all means, you got reflux. That's the diagnosis. So, and you got a problem. I don't know what kind of surgeon you're seeing, or why, but if you have acid reflux, the barium comes up. I haven't followed up with EGD. EGD, examination of the esophagus, the vast majority, 80% of people with respiratory reflux have normal esophageal exams. And the reason is the esophagus has robust anti-reflux defenses. 50 reflux episodes a day on pH testing is considered normal. You can have 2 a week in the pharynx. And when do they test you, on a Tuesday, Wednesday? What about Saturday night? So it doesn't take much reflux into the respiratory tract to cause damage, particularly in the lung. If you reflux, microaspiration gives you a ground glass Christmas tree looking chest x-ray, sometimes with little nodules. Please understand that these are probably, in most cases, reflux related. So barium swallow is no good either. It's not a diagnostic test. Endoscopy is not a diagnostic test. Bravo, I did ambulatory double probe pH monitoring with a sensor here and a sensor here, using the best chip that was available in the day, the ISFET chip that you get on a $1,000 pH meter. I have data like no one has ever gotten, okay? And now they're doing, putting a little capsule in the lower esophagus called Bravo. And by the way, they get a lot of money for that. and it's useless for respiratory reflux. So if they say you have reflux, fine. If they say you don't have reflux, you still have reflux if you have the complete constellation of symptoms. I had a person see one of the top people in New York who I consulted with recently, and the doctor saw him 3 times and said, I can't help you, and that was it, and sent him away. The patient had unbelievable reflux when you looked at his clinical pattern, including a chronic cough and shortness of breath. The patient had already been all the other doctors. So, all right, so now we have the res tech, that's no good. So the answer is, inevitably, it's going to be physical examination. I can stick a scope in somebody and not only tell you whether you have reflux, I'll score it. So anything above 14 is an F. But even though you're not doctors, let me tell you, I think they're going to end up being 3 findings that tell the story. The back of the larynx is usually thin, and the back of the throat is here. When this back of the larynx is so swollen that it's in touch, if the two of them are touching, you have supine nocturnal respiratory reflux. Read that one, snore, S-N-O-R-R. And so that's a pathognomonic. That means it could only be one thing. It's respiratory reflux. You don't need a CT scan. You need a reflux program. So that's number 1. And it's called the postcricoid area, and it's so swollen it touches the back of the throat. The second is that there's a thing called the ventricle. It's just a space between the true vocal cords and false vocal cords, and that gets swollen shut. And the third is that the vocal cords become swollen. They don't have that nice, look like the bow of a ship shape anymore. So those are the 3 findings that doctors need to look for, and stop with worrying about, red retinoids and all that. In my opinion, red retinoids means you reflux last night or maybe the night before. And remember, you don't have to reflux but a few times a week and have respiratory disease of significance. So, best test for acid reflux? There isn't one. Not if it's respiratory reflux. Can LPR, Catherine, cause pain in one ear? Yes. Here comes one that I get asked all the time. And I think I wrote an article on it on the blog. How do we determine whether I have low acid or high acid? And the answer is there's no such thing as low acid except for a disease that's rare. And low acid is not a problem. Taking acid pills is terrible for reflux. Taking enzymes, all these things that people are doing to try to get over the top, they don't work. So we've done, every time we do a pH test, the first thing we do is to go in the stomach, to read the pH there. The pH of stomach acid is around 1, 2, 3, and we see stomach acid before we pull it back in the esophagus to do the test. So in my experience, one patient in 40 years of reflux testing, I didn't have enough, and that person had pernicious anemia. So low acid is not a thing. It's just not a thing. This one drives me up a wall. This is really, you gotta laugh, okay? Can I pH balance almond juice or a Cosmo with putting alkaline water drops in it? It's the alcohol that causes, alcohol after eating too close to bed. Alcohol is the number 2 reflux trigger there is. Sorry, it just is. And so if you're going to go on a reflux program, by the way, and you drink alcohol during that, let's say, 4 week of that month, there's no alcohol either. It's a dry October. So the answer is no, you can't take something acidic and put some alkaline water drops in. Alkaline water drops are available. I did an article on them. People said, do they work? If you type in alkaline water drops, that article will come up. And of the 4 I tested, 3 of them work quite well. And they give a nice high pH. This is the hiatal hernia question again. I have a sliding hiatal hernia pushing up into the esophagus all the time, going to keep aggravating the sphincters and causing out. So the hiatal hernia is not the cause of any of this. Okay? Reflux is caused by, and you have a lousy, reflux is self-sustaining. The more you reflux, the more inflamed, stiff, and swollen is the lower esophageal sphincter, the more you reflux. Sometimes the esophagus gets lazy, people get dysmotility, pills getting stuck, and so on. And finally, the upper valve kicks out. So when you lie down at night, what's in your stomach is in your esophagus, is in your throat. So, yeah. Oh, the hiatal hernia person also did a detox diet. And remember, diet's not the whole deal. Can I use alkaline water in a steam vaporizer or a nasal rinse to get rid of pepsin in my upper respiratory tract? Seems like it would work. Janice, good idea. I've never, really recommended it, but I'm sure you can get the little ones you put at your desk or whatever, and do it 3 times a day after meals, whatever. Wondering what your thoughts are about speech therapy for throat clearing. And a lot of people are told it's a tick. It's not. Okay, it's the number one symptom of respiratory reflux. Too much mucus, postnasal drip, chronic throat clearing. 88% have part of that. So, no, I don't think speech therapy is for that. I don't know who would recommend it. Now, this is a good question. This is from Kat, from New Zealand. 10 years post-gastric sleeve, been suffering with heartburn and reflux for about the last 5 years, treating it with all this other stuff. And she has erosive esophagitis, and she's on pantoprazole twice a day. And so you're in a unique situation, in my opinion. If you were my daughter, I'd say get a bed that goes up and down, learn how to sleep very high. Don't eat anything after 5 o'clock if you go to bed at 10 or 11. Eat small meals in the evening. Don't overeat in general. Stay away from trigger foods for the rest of your life, and take an alginate before you go to bed. And finally, use alkaline water and alkaline water spray. So if you have that situation, that in fact of the types of bariatric surgery, this one is the worst reflux-wise. So most people who've had that have reflux, and you have it big time. And 40 milligrams of omeprazole twice a day. Ouch. I've written 4 articles on proton pump inhibitors, and I think they're probably not, they should be taken off the market, and they will be one day. So time is basically up. So people who want to know, should they drink alkaline water? Should they get DGL? Should they take enzymes? I've been on the diet, and so here we go. Here are 10 articles. They're all, just type them in a little box, and up they'll come. Pepsin, number 1. 2, intermittent fasting. I'll go slow. 3, eating dinner too early, relative to lying down and going to bed, and no snacks after dinner either. 4, type in reflux detox. You don't need my book. There's the reflux detox diet. 5, alkaline water, and you want the article with the man who looks like he's made out of water. 6, famotidine is an article on generic pepsin. Alginates. Alginates are Gaviscon Advance, Reflux Graft, and Reflux Gourmet. I'm still a recommender of Gaviscon Advance. Chewing gum after meals is very important, especially during detox. When you chew gum, you make more saliva, more bicarbonate, you swallow a lot more. So we studied this. We had a man who had reflux who wasn't under treatment yet. So we put a pH probe in, sent him out to lunch, and he came back refluxing like a bandit. I said, chew gum. Boom, down went the reflux. So and the same is true of a hard candy. If you're in a situation where gum chewing isn't appropriate, you can suck on a hard candy. We put Ricola cough drops, the big square ones, in Carnegie Hall for people to take, and the noise level in Carnegie Hall went down a lot. Read the article on breakfast, it'll give you ideas. Read the article on pH balancing. And I also recommend the article on rice, the article on ginger, the article on chamomile. And a lot of these articles are short, and they'll give you a lot of information. There's a good one on chocolate as well. So I'm going to read this 10 back. 1, pepsin. These are blog posts. 2, intermittent fasting. 3, eating dinner too early. The dangers of snacking too close to bed, I think is the name of the article. Reflux detox. Alkaline water. Famotidine. By the way, it is 8 times more potent as an acid suppressant than Zantac, which we used for 20 years. Has no side effects to speak of. It is the safest, most effective medicine in the world, in my opinion. It does more better with less trouble. Alginates, you know what they are. Gaviscon Advance is my choice. Gum chewing, don't get anything with mint in it. I personally like cinnamon without sugar because the flavor lasts longer than like juicy fruit and bubble gum. But hard candy will do. Read the article on breakfast. It'll give you a lot of ideas. And then finally, pH balancing. There are other ones. And if you spend an hour a day on the website, a week from now, you'll know more about reflux than 99% of the physicians in America. I know that's a brag, but it's true. So anyway, so long, everybody, and thanks. I'll see you next month.